Welcome, everybody. My name is Karen Lewis with Willamette Valley Hospice and Palliative Care. I just want to welcome you today to our third and final webinar for Untangling the Challenges of Aging, Vital Decisions. Today, we're going to talk about Medicare and Medicaid and who pays for what. I'm your host, and I have a special guest with me today, Hope Crump, who is a licensed Medicare agent. I'm very excited to have her with us today to speak about Medicare and Medicare options. Before we get started, I wanted to run through a couple of things, do a little housekeeping. We have a chat on the right-hand side of your screen. And if you have a question, feel free to add it into the chat. We will do questions at the end. And we have a number of resources that we're going to actually talk about. So you will also get those resources in a handout that we send out to you tomorrow, along with a link to this presentation once it gets uploaded on YouTube. So if you missed something today, don't worry. Everything's fine. You'll get to see this tomorrow, and you'll also get a handout with all the resources we cover today. So without any further ado, I just want to introduce Hope. She is a good friend of mine who we used to work together, and for the last 4 years, she has been a licensed Medicare agent here in Salem, Oregon. She's a thriving business and just opened her offices off of Battle Creek in South Salem. So Hope, thank you so much for coming, and I just want to welcome you to this presentation.
Thank you, Karen. All right, well, we're going to start by talking about Medicare. So what is Medicare? Medicare is health insurance that's provided through the federal government, generally for people who are 65 and older. It's actually part of Social Security benefits. So, you get your Social Security benefit, and then Medicare is actually part of that. So you actually apply for Medicare directly with Social Security. And Medicare is anyone who's a U.S. citizen or who's been a legal resident in the U.S. for at least 5 years is eligible for Medicare. And then the two most common misperceptions that I find regarding Medicare is that it's free and that it covers all the costs of healthcare in retirement. In reality, there is actually a monthly premium for Part B, so it does have a monthly cost. And there is cost sharing with Medicare. So Medicare does not pick up all the costs of your healthcare and retirement. There are deductibles, co-pays, and what we call co-insurance. So essentially Medicare pays 80% and you would pay 20% of the cost of some services. You can go ahead and change the slide, thanks. Medicare Part A, so we'll kind of break it down. There's two main parts. Part A is what we call your hospital benefit. So Part A covers inpatient hospitalization, and that's key. You do actually have to be admitted into the hospital in order for that to be covered under Part A. Sometimes people spend the night in the hospital and they find out the next day that they were actually under observation. And if that happens, that's actually going to be covered under Part B, not under Part A. It also covers your skilled nursing. So Medicare does have some rules about when they'll cover skilled nursing. You do have to have a 3-day inpatient hospital stay prior to entering the facility. You do have to be under the care of a doctor, receiving physical therapy, and making functional improvement. And that functional improvement is a key term to determine whether or not Medicare is going to pay for care. And so we will actually come back to that a little bit later. And then Medicare covers up to 100 days of skilled nursing per benefit period. So that's per incident. Although most people do get released usually around 3 weeks, after about 3 weeks of skilled nursing care. Part A, oh, can we go back, Karen?
Sorry.
Thank you. That's okay. Part A also covers home health care. So that's skilled intermittent care in your home. Generally going to cover up to 3 weeks of that as well. And then Part A does also cover hospice care. Okay, now we could go to the next one. Medicare Part B is your outpatient. That's your outpatient benefit. So that's going to cover things like doctors, surgeons, ER and urgent care, radiology and labs, and the ambulance. There is no monthly premium for Part A. That's no cost to you as long as you paid into the system for at least 10 years or your spouse has. But Part B, as I mentioned before, does have a monthly premium. So most people pay $148.50 a month this year, but that will be going up, and it does generally go up every year. So next year, we're looking at about $170 a month. The premium's paid directly to Social Security. So if you're already receiving Social Security benefits, they're actually just going to take that money out of your benefit before they even deposit into your checking account. If you're not taking Social Security benefits when you go on Medicare, then you'll actually get a bill from Social Security for that premium. So Medicare coverage options. Most people do not stay on original Medicare, that Part A and B, that red, white, and blue card that you see there on the left-hand side. And the reason is that your biggest risk to staying on original Medicare is that Medicare does not limit your out-of-pocket expenses. So there's no max out-of-pocket. So if you have a lot of health issues or serious health issues, you're just going to keep paying those deductibles and copays and cost share without any limit. So that's why most people do get some type of supplemental coverage with Medicare. And it breaks down into two main options. So most people either do a Medicare supplement or a Medicare Advantage plan. So option one there on your screen is a Medicare supplement. They're also called Medigap, so you might hear those terms used interchangeably. And a Medicare supplement is secondary insurance with Medicare. So you actually purchase it through a private insurer, and it is going to pick up some or most of those out-of-pocket costs with Medicare. The premiums are typically higher with a Medicare supplement, and they do tend to increase as you age. The other thing about the supplement is that Medicare is primary. So if you have a supplement, your primary insurance is actually coming through the federal government through Medicare. So that supplement is not going to cover anything that Medicare does not cover. The other thing to know about the supplement is that in order to get your prescription drug coverage, you do need to get that as standalone. So the Social Security does not provide prescription drug coverage. You always have to go to a private insurer to get that. So in option one, you'd actually just have to get what we call a standalone Part D. The other option is to go with a Medicare Advantage plan. And the Medicare Advantage plans are, the supplements have been around a long time, pretty much since Medicare started. Advantage plans are relatively newer, but they're becoming more popular as well. So particularly in areas where we have a lot of Medicare plan options, so Marion and Polk County, we've got over 25 plan options here. So I see these plans are very popular. More and more people who are going on Medicare are choosing to do an Advantage plan. You can change to the next one. So Medicare Advantage plans are also, you would also go to a private insurer for an Advantage plan. Sometimes they're called Part C. So again, you're going to see those terms used interchangeably, but they're the same thing, Medicare Advantage, Part C. In this scenario, the insurance company is actually contracting with the federal government to take over Medicare. So rather than showing that red, white, and blue card when you go to the doctor, now you're going to show your insurance card. And the insurance company is now going to provide Part A and B of Medicare. They're going to pay the claims. They're going to manage the benefits. It's pretty typical to see some additional benefits built into those plans. So things that Medicare does not cover, like dental, hearing, vision, gym memberships, transportation, very typical to see those built into an Advantage plan, and then your prescription drug coverage as well. So that's all going to be wrapped into one. The Advantage plans do have lower premiums, generally speaking, than the supplements, but there are copays for most of the services that you would receive. There's also a max out-of-pocket limit. So this is really how the Advantage plan is removing that risk from original Medicare. Every single plan will have a max out-of-pocket. And if you reach that max out of pocket, then you're done paying for the rest of the year. Next slide. So I'm going to go ahead and introduce Mildred. We're going to talk about her throughout this presentation. She's 84 years old. She's widowed. She receives Social Security and a small pension. Her monthly income is $1,350. Her assets include her home and a retirement account with a balance of $12,000. Last month, she fell twice. So the first time she fell, fortunately, a neighbor happened to come by not long after and found her, called 911. She was taken to the hospital. They checked her out. She was a little banged up, but fortunately not seriously injured. They kept her overnight under observation. And then the next day went ahead and released her and she went home. 2 weeks later, she fell again. This time her windows happened to be open. It was summertime and she was yelling for help and somebody heard her and came by. Again, called 911. She went to the hospital. Fortunately, she was not seriously injured. She was pretty well bruised up. But when she got to the hospital, they discovered that she had the flu. So they went ahead and admitted her. She was inpatient in the hospital for 3 nights. And then she was released to go to rehab. So she was receiving physical therapy and care in rehab. And she spent 10 days there and then was released to go home. But at this point, it's become pretty clear that to Mildred's friends and family that she cannot live alone anymore. So now they're looking into her options for assisted living. So Medicare, in her scenario, Medicare covered her stay in rehab, those 10 days, because she did have a 3-day hospital stay prior to going into the facility. She was making functional improvement. But now that she's come home, she is no longer making functional improvement, and now Medicare is not going to cover any of the cost of her assisted living. So now we'll talk a little bit about that. So we've moved away from skilled nursing, Medicare, into now what we call long-term custodial care. So long-term care is generally defined as needing the assistance with the activities of daily living. So that's eating, bathing, dressing, transferring, toileting, walking or moving around, or the need, or the need for assistance due to a cognitive impairment like Alzheimer's or dementia. So these are just some statistics about long-term care. Someone turning 65 today has a nearly 70% chance of needing some type of long-term care services in their lifetime. I will say that statistic has gone up. I would say several years ago it was probably closer to 50%. That's what we were estimating. So obviously, if you're married, it's a very good chance that one of you or your spouse will need long-term care at some point. Women typically need care longer, so on average 3.7 years than men, which average about 2.2 years. The average stay in assisted living is 28 months, and 20% of those needing care will need it for longer than 5 years. So typically we're looking at, in the case of assisted living, needing care anywhere up to 2 years to around 3.5 years. So this slide is just showing you what the cost of care is right now. So you can see right off the bat, it's expensive, particularly if you're looking at a nursing home. And the other thing you'll see here is that the average monthly cost in Salem for care does tend to run a little bit higher than the average monthly cost in the state. And I would say that's pretty consistent, that we see the costs here in Salem are just a little higher than the state averages. So now that you've gotten a look at what it costs, what are your options for paying for care? Well, there's a few. Long-term care insurance was historically how a lot of people addressed the cost of care. But to be honest, if you're already in your 60s or, past age 65, long-term care insurance is generally not an option at that point for a couple reasons. One, it's very difficult to be eligible for long-term care at that point in life. They are going to look at pre-existing health conditions and your health history, and usually people at that age just aren't even eligible anymore for the coverage. Even if you are eligible at that age, the premiums are pretty much cost prohibitive at that point. So, if it's later in life, long-term care insurance, not an option. If you've purchased a long-term care insurance policy in the past and you still have it, I always say hang on to it if you possibly can. Your other option, of course, is to private pay. So if you have the means to do that, that's an option. And then another option is the short-term recovery care insurance. This is a product I actually do work with my clients. So if you've got questions about it, feel free to, my contact information will be up at the end. You can contact me and I can give you more information about that. But basically, as the name implies, it's designed for a short period of time. And it's also very flexible. So you can use it in the nursing home, you can use it in assisted living, or you can use it for in-home care. You can purchase up to 360 days of care. And it does not need to be used consecutively. So I think of it as being helpful in one of two ways. Either essentially buying you time before you have to dip into your assets to pay for care. So you can buy yourself up to a year's worth of time. Or if you have a primary caregiver like a spouse or a child who will be taking care of you, the short-term recovery care insurance can help with respite. So it would allow you to possibly bring someone in maybe 2 or 3 days a week and give that primary caregiver a break, essentially. And then that last option is Medicaid or Medicaid spend down. So Medicaid is state assistance with the cost of care. Currently, 45% of Oregonians rely on Medicaid to help pay for care. And I'll just make a comment about that statistic. Most assisted living facilities set aside about 15 to 20% of their beds for Medicaid. So you can see if nearly half of Oregonians are dependent on Medicaid to help cover the cost of their care, we do have a shortage of available beds for people on Medicare, or excuse me, on Medicaid. So if you're thinking that's the direction you might have to go, is to utilize Medicaid at some point to help pay for the cost of care, my advice is to get started on that process earlier than later, because quite often you will find that there are waiting lists at facilities for Medicaid beds. So at this point, if we're talking about Mildred, it's really too late for her to do long-term care insurance or short-term recovery care. Obviously, she cannot pay for the cost of care with her income and assets. So she's really at the point now where she's looking at a Medicaid spend down. So I'm going to go ahead and hand it over to Karen, and she's going to talk more about Medicaid.
Okay, great. Thank you, Hope. Really appreciate that.
You're welcome.
We're going to we're going to go back to Mildred in a little bit and see what kind of options she has for Medicaid. So, but just to start, I just want to say that in Oregon, Medicaid is called the Oregon Health Plan, and it's run by the Oregon Health Authority. So when you think about Medicaid, it is there are some federal monies and then there are state monies, and they are put into a pot together, and then the state actually runs the Medicaid program. So just like, unlike Medicare, where you were actually on a federal program, when you move to Medicaid, you actually move to a state assisted program, even though some monies in that pot will be federal dollars. So it's a wide-ranging, jointly funded state and federal health care program for low-income folks. So who can get help? Well, first of all, you have to have a financial or resource limitation. You need a disability. You need to be 65 years or older, and for straight Medicare, or what they call regular Medicare, you need a monthly income of less than $794. That's very small amount of money for a single person, unless you are service eligible. And we'll talk about that in a moment. And your assets need to be under $200,000, $200,000, that'd be great. But no, under $2,000. So what does Medicaid really cover? Well, it covers many medical items that you need for your care. And I just lost my presentation. Let me just get back here. Here we go. Any doctor's visits, care in your home, specialists, your primary care physician, and any specialists, any vision, dental, mental health visits, and even transportation if necessary. The care in your home, whether that be in your personal residential home or in an adult foster home, a residential care facility, an assisted living facility. It can also cover your medical equipment, so wheelchairs, walkers, any oxygen you may need, and then any medical supplies like incontinence supplies, colostomy bags, bandages, wound care products, anything like that. Some prescription drugs it covers, and then therapy visits, primarily physical, speech, and occupational. So let's talk about the types of Medicaid. And for this, I'm going to use my little pointer. There are three types. So institutional or nursing home Medicaid that we refer to. The income limit for that is $2,382. That's quite a bit more than the regular Medicaid, which is $794. So these two programs, the top one on top and the one on the bottom, are entitlement programs. They are in. So if you have and qualify for the programs, you can receive services. The third one here is in the middle is Medicaid waiver, or what they call home and community-based service program. You can have an income limit of $2,382, and you can receive care in your own personal residential home or an adult foster home, assisted living, that kind of thing. They call it community-based home and community-based services, which the word community really means the difference between nursing home care and your own any other kind of care, any other kind of care home you would be in. So if you qualify for these, which they're not entitlement programs, if you qualify, they're run by the state specifically, and they're often limited. So it may be because they have a number of participants, or they may limit the number of participants for waivers due to a certain kind of diagnosis like Alzheimer's or dementia, or a certain geographic area. So it's really up to the state to make that determination, but they are available. So all of these, however, have an asset limit of $2,000. So let's move on to go back to Mildred. So Mildred is still in a rehab setting, but she's not making enough progress and she's going to need more care. So her monthly income is $1,350. She doesn't meet the income criteria for straight Medicaid. Remember, that was $794, but she does meet the income criteria for a nursing home or for an assisted living or adult foster home, which was one of those home and community-based service waivers. And she is service eligible because she's not able to maintain her activities of daily living. She may still have problems with her mobility or transferring or, dressing, eating, those kinds of things. Her assets are her retirement account of $12,000. And I think in the previous slide, we had a home in there as well, and we'll talk about that specifically in a minute. But she can either, if she just has the retirement account, she can either spend down the $10,000 to get to the $2,000 limit, or Medicaid may ask her to put that money in a specialty trust before approving her for Medicaid. If she were to have a home, this is where things get a little sticky. After talking to a lot of my colleagues in different communities, they said that it is not unusual for Medicaid to, if someone is in a home and they're not making functional improvement and they're going to need to be in a nursing facility or some sort of other type of home care, it is not unusual for them to ask to have that house listed for sale and then provide proof. So that means they're working with the POA, the power of attorney, or the patient themselves, the one applying for Medicaid. So let's move on to what income and assets are. So income includes any kind of employment, wages, alimony, pension, all of the usual things, not your coronavirus stimulus checks, unusual, but that's what, according to the American Council of Aging. And then your assets are anything that's easily converted to cash. So it can be checking, money market savings, vacation houses, investment property, and things like that. It does not include prepaid funeral expenses or some types of life insurance and or household items and other personal items. So how does one get started? Mildred's in a situation where she's going to need to move back into some sort of care facility. So where does she get started? Well, if she has a daughter or family member or someone who is her power of attorney, we suggest that you really get in touch with Aging and Disability Resource Connection here in Oregon. In fact, many of my colleagues who work with families day to day say that this is the easiest way to get in touch with folks, either through an attorney if they have one or the ADRC. And often you can just call them and ask to speak to an options counselor. You're not paying for anything, you're not applying for anything yet. You're just saying, I want to see what my options are. But the ADRC have specially trained counselors who can screen your situation and let you know if you meet program rules and guidelines. They can also help you apply. But more than that, if you don't immediately qualify for Medicaid, they also have independent programs that you may qualify for, like the Oregon Project Independence Program or the Family Caregiver Support Program. Many of these programs have monies attached to it, and so it's important for you to talk to somebody at their offices so that you can get more information about those programs and see if you qualify even before you think about Medicaid. The other thing I wanted to draw your attention to is the planning guide for the future. Now, a couple of weeks ago when Melissa, Kevin, and I don't know if you remember Susie Deeds was presenting, Susie Deeds talked just briefly about this Planning for the Future pamphlet. And it has a lot of information in it, which talks about staying in your home, giving you a financial checklist for determining your income versus your medical costs. But more importantly, which I thought was really valuable, were some of the questions that Cheryl Sodor talked about last week when she was talking about senior care options. And in the back of this this brochure are all the questions that Cheryl had talked about, and then all the columns where you can simply check a box. So when you're looking at communities and what kind of community you want to go to, and you're trying to compare and contrast, this little booklet is incredibly handy because it gives you all the questions and all the information in one little piece. So it's incredibly valuable. So I always encourage people to grab that. And then we have some other resources that we want to tell you about. Obviously, the ADRC, their phone number is there along with their website. But do you have an attorney? You need to meet with them if you're thinking about going into Medicaid or going on to Medicaid. If you don't have an attorney, what do? Well, you can call the ADRC and ask for a list of local elder law attorneys in your area, or you can grab a Retirement Connection booklet, which you can usually find at most grocery stores. Fred Meyer's has them. Any of our senior centers in and around Salem will have a Retirement Connection. A lot of elder attorneys are listed in there as well. Most of the information I shared with you came from American Council on Aging, but they have a wonderful Medicaid spend down calculator. So if you can't get in to see someone at the ADRC and you need to start planning right now, or you want to see how much information you need, or how your finances compare to getting onto Medicaid, this is a wonderful tool right here. The MedicaidPlanningAssistance.org. You can go on there and it will do it specifically, give you your eligibility for the state of Oregon. And then for many of you, I don't know if you're thinking or you're watching this presentation today, you may have also known that there was a presentation earlier this week from Center 50 Plus, which is the Salem Senior Center locally in Salem here. And they had Monica Pachenko, who's a known elder law attorney here in town. And she talked about answering questions about Medicaid 2021, very specifically because she's an elder law attorney. So if you have more questions about this, and this is just a little snippet of information, you can go and check out that presentation as well. You can jump onto Center 50 Plus's website, actually their Facebook page, I apologize, their Facebook page. They will have the link to that presentation. They recorded it on Monday. They'll have the link to that on Friday, so you can take a look at that. And then I just want to thank you for joining us today. And I'm going to ask Hope, is this the information where someone can get in touch with you, Hope?
Yes. Yeah, my phone number, email, either way, you can text me, call me, email me, whatever works for you.
Great.
And my website was on there too, on my card.
Okay. Did I stop sharing the screen? I apologize. I wanted to talk about the questions and answers here that we have. Let me just get back here for a second. Sorry, folks, we're having technical difficulties. Okay. There we go. So, can you see it now, Hope?
Yep, I can see it.
Okay, so you're at hopecrumpagent@gmail.com, and your number is 503-551-5475, right?
Yep.
And then if you have any questions about things you'd like to see in the future with Untangling the Challenges of Aging, then you can certainly give us a call at our main office for Willamette Valley Hospice and Palliative Care at 503-588-3600. The reason we did this presentation today, I'm going to stop sharing the screen, by the way. The reason we did this presentation, by the way, was that many of us in this community, when we were working with is on Medicare, and they have to switch over to Medicaid, and that's usually a very short period of time because of that term functional improvement. And actually, Hope, we have a question in there about functional improvement, and I wanted to ask you, when you mentioned functional improvement, how is that determined? Is that by a doctor? Is that by Medicare? Is that a joint?
Generally, it's going to be the doctor. So that is part of the rules with skilled nursing, is that you do have to be under the care of a doctor. So generally, it's going to be the doctor making the determination whether or not there's functional improvement. I don't know the specifics of what they're looking at, but that's generally who will actually be deciding whether or not. Essentially, they're approving a certain amount of skilled nursing, and then they'll keep approving it if they think that they are seeing functional improvement.
Okay, great. And then we have another question. Do you notice that for most people that Medicare Advantage plans make the most sense financially when considering coverage in general? And then there's secondary, do you get more coverage for less?
So I mentioned before that Medicare supplements have been around a long time, and historically that was it. Those were we didn't have Advantage plans. So if you wanted help or to contain your risk with Medicare, that's what you did. Personally, it's pretty rare that I actually, when I meet with someone, would actually say you should consider a supplement. Generally speaking, they work really well for people who have chronic conditions that are being treated. So, even someone with diabetes, for example, that's a chronic condition, but their biggest expense, generally speaking, on Medicare is the cost of their insulin. Well, a supplement isn't going to help you with that. So if you have a chronic condition that's actually being treated in a doctor's office or in the hospital or something like that, oftentimes the supplements will save you money over the long term. But I do find that for most people, even if you have a bad year, if you get a cancer diagnosis one year, or you go into the hospital a couple times one year, over the course of your lifetime, what you save in that annualized premium, I do find for most people, the Advantage plans do save you money in the long run. And of course, you do have that protection of the max out of pocket. So essentially what your worst case scenario is in any given year. And then the question is, do you get more coverage for less? Yes, I would say absolutely. The thing about the Advantage plans is they have to be at least as good as original Medicare, and they're almost always better. So even things that maybe Medicare would say, we're not going to cover that, sometimes the Advantage plans do. So I mentioned dental and vision and hearing and things like that. But even like if you think about that rule for skilled nursing, you must have a 3-day hospital stay prior to entering the facility. Most Advantage plans actually waive that rule. So that's one thing that can trip people up. They might spend 3 nights in the hospital, get put into rehab, and then they find out, well, actually the first night you were under observation. So you actually only spent 2 nights inpatient, and they get hit with that bill because Medicare does not cover skilled nursing at all. So if you were on a supplement, Medicare is not going to cover that. So guess what? You're going to pay full board the cost of that skilled nursing stay. Whereas an Advantage plan would have paid because they waive that 3-day hospital rule. So really the Advantage plans, I think, work really well for a lot of people, and they're designed, I think, with the needs of, that you're going to face at age 65 and older built into those plans. I think they do a really good job in that way. Yeah.
Okay. Thanks. There's another question here that is really great, and I wanted to talk about it a little bit and kind of give a little scenario. When I was talking with my colleagues that are in communities and that work in social services and communities, and one of the reasons we did this presentation today was to talk about that little transferred piece between Medicare and Medicaid, because it's sometimes a very short window of opportunity between the time that Medicare says, we're not going to pay for your care anymore, and and by the way, you either have to come up with X number of dollars, or you have to sell your home, or you have to do whatever, or you have to go into Medicaid. And it's gut-wrenching for a family who is grappling with the idea that their loved one is declining, and they're not getting better faster, because they're usually in their 70s, 80s, 90s. They're not 20 anymore, so their body's not responding like they used to. And then now you have Pandora's box, and you have to open this up and deal with all of this stuff that's Medicaid. So what my one of the colleagues I talked to, who works at a community out in east of Salem, had mentioned to me was that she usually will just sit down with a family immediately and say, hey, listen, this is what is happening. Medicare is not going to cover after the next 3 days or whatever. Have you thought about, other forms of payment? That's when they have the conversation about private pay. That's when they have the conversation about assets and things like that. If that family is open to that conversation, and that person needs to go on Medicaid, that process, she said, can move quite quickly, depending on the family's cooperation and ability to get bank statements and forms in place, and any kind of asset documentation. But One of the questions that came up, Hope, and this is a really great one that Mike had answered, was asking was, what is short-term care insurance again? And can it be used for someone who's covering the day rate of a rehab to buy a little time while they're waiting for Medicaid to be approved?
So short-term care insurance is, so the way that you qualify for the insurance to kick in is either the loss of 2 or more of the activities of daily living and or cognitive impairment. So, and you can use it. Yeah, absolutely. You can use it while you're waiting for Medicaid to be approved. So that's the beauty of it, really, is, no, it's not going to last you 3 to 5 years, obviously, but depending on, the policy you choose, you can cover 90 days, 180 days, 360 days. And as long as you meet, one of those 2 parameters that I just mentioned, the benefits will kick in. You also choose the waiting period. So another thing with long-term care, it's very typical to see a waiting period of like 3 to 6 months before the benefits will start. Short-term recovery care, you could pick 0. You could have it start right away if you wanted, or you could say you want to start in 2 weeks. I usually recommend 2 weeks because, like I said, Medicare covers skilled nursing usually up to about 3 weeks. And actually, Medicare pays 100% of the cost of skilled nursing for the first 20 days. But yes, if you were in a situation where now you've got that daily copay, you're still in skilled nursing, is still being covered, but you got a daily copay, or Medicare's not paying anymore, and now you're totally responsible for the cost, you absolutely can use it for that. The other thing about short-term recovery care is that the benefits actually reset. So if you have a full recovery, I think it's for more than 6 months, you basically get right back to day one and you have those benefits completely reset. So if you had a situation where maybe you were utilizing it just to bridge a gap, you went home, had a full recovery, and then later on needed to use it again, you could do that too.
Okay, thanks for that. That's really great information. And one of the other things that the other question we have said, they said, do you have to have an attorney to apply for Medicaid? And that's a really great question. You do not have to have an attorney to apply for Medicaid. I gave you the information for the Aging and Disability Resource Connection. That is a office of the Northwest Senior and Disability Services, and that whole office is. They have specially designed counselors who are options counselors, but then they also have assessment caseworkers that work on Medicaid eligibility requirements and things like that. So as I mentioned, my colleague over in the East, all she does is pick up the phone and say, I'm requesting benefits for this person. Here's their name, social security number, and here's their power of attorney, daughter, son, whatever, and here's their phone number. A person, just you and me, can do the very same thing. We can just call up and say, hey, listen, I think I need Medicaid benefits, and they can bring you in and do an assessment of your needs right there. So you do not need an attorney. It is an option, though, for a lot of people that they have other assets and things, and they already have an attorney, so it's a good idea for them to meet with them. But no, if you don't have somebody, you don't need an attorney to apply for Medicaid. No. There is another question down here that I wanted to make sure we catch. Does a Medicare Advantage plan limit which doctors can be seen for medical care? I'll let you have that one, Hope.
Okay. So original Medicare, if we're talking about Medicare that's coming through the federal government, does not have a network of providers. So you can go see any provider anywhere in the country that takes Medicare. The Advantage plans do have a network of providers. So depends on the type of plan you're looking at. HMO plans limit you to only seeing in-network providers. PPO plans do allow you to go out of network. You just pay more to do that. And there are some carriers that they're big national Medicare Advantage carriers, and they actually, if you have one of their PPO plans, you can actually access their national network and pay the in-network cost sharing. So even though that sounds kind of restrictive, that you've got a network of providers, a lot of the carriers that we have here that are providing Advantage plans do have extensive networks up and down the I-5 corridor and even nationally. So I find for most of my clients, that's really not prohibitive. That's not an issue. And if you've been on insurance, if you've had individual insurance or group health insurance, you're already used to that, because those carriers do the same thing. They've got doctors that take their plans and doctors that don't. But that's the other thing, if you're looking at an Advantage plan, for sure, this is what I help my clients do, check your doctors, make sure they take the plan that you're looking at, or find a plan they take. That's definitely an important thing to do.
Okay, great advice. One thing I wanted to super qualify is that you are a licensed Medicare agent in town, Hope, and I am not a licensed Medicaid worker. So everything that I'm sharing with you is through either research that I've done for this presentation, but I strongly encourage you to reach out to the folks at ADRC if you have more questions about Medicaid specifically, or your own attorney. So thank you so much, everybody. I think that answers all the questions we have. I just want to say thank you so much, Hope, for being with us today and giving us some information and helping me work through some of these issues with the people that we work with every day. I know this is a time of life where we hope that things get a little bit easier, but sometimes with all these different programs, it's important to sit down and start thinking and planning ahead, just so that as we go into this best time of our life, that we have these things kind of planned out and we know what is coming and what to expect. So thank you so much. Thank you, everybody, for being with us today. If you have any questions at all, or we didn't get to your question today, go ahead and send us an email. We will include it in the email that we send out tomorrow with the link to this presentation. Again, thank you so much, and special thanks to Taylor Van Amberg, who is behind the scenes helping us with today's webinar. Thank you. Thank you. Take care, everybody.
Thanks, Karen.
Bye-bye.